Hi, my name's Ian Battersby. I'm head of the Internal Medicine Department at Davies Veterinary Specialists, and welcome to the second part of Davies Out of Hours, based on management of a patient with a linear foreign body. I'm here with Ronan, Doyle, head of our soft tissue service, and we've just, as you know from the part one, we're down at the Live and Let Live in Pegston. And just to recap, in the part one, I made a diagnosis of a linear foreign body and went to theatre, and Ronan was just talking us through how he assesses those patients, how to assess intestinal viability, how to go about removing the foreign body, working in a very logistical way, and then, very importantly, how to optimally place your sutures to try and hopefully minimise risk of dehiscence. So now that patient's out of theatre and it's in wards, and the next important part is creating a plan of monitoring. So once we start, there's a lot of different things to talk about. There's
absolutely.
Analgesia, feeding, ileus. So we start with, I suppose, analgesia.
Yeah, sure.
Probably.
Absolutely. I mean, this is where we absolutely get the team involved. So that the nurses, the anaesthesia team, and ourselves to figure out. But I suppose our basic plan for most of these patients is, we're going to continue to cover them on opioids, and that's normally methadone. So we're going to continue on with that. So every 4 maybe to 6 hours depending.
Okay.
And certainly this is immediately in that first 24-hour period.
Okay.
We'll normally give them paracetamol.
Okay.
So we use quite a lot of that now in the practice, and we good support for the use of that as well in dogs, obviously, just not in cats. And we'll use that in preference and generally avoid the use of a non-steroidal anti-inflammatory.
Absolutely, because of the gut.
Yeah,
You're operating on the gut.
And also some of these dogs have been potentially quite unstable. There's maybe blood pressure issues or challenges. So we'll be hanging off using a non-steroidal until maybe later, but not generally at this stage.
And what about, because as the medic inside me, I'm just thinking, this intestine might not be happy, and you've given it an opioid.
Oh yeah. So
there might be a degree of ileus. Yeah. And we might.
Yeah. Well, that is the medic inside you, I think. To be honest,
you're like whatever.
I mean, it's true. We do know in people certainly that when you give pure agonists, it decreases intestinal motility, and it's concerned. I think we probably overplay it. To me, the key thing is that these patients are as comfortable as possible. Because in essence, pain might make them stress and promote an ileus. And make things worse there. And you don't want them in pain because that's going to make everything worse. In fact, pain even impacts on wound healing, and so forth.
I suppose just touching, before we move on to the other bits like feeding and things like that, if you have a patient that you are concerned that's got ileus, there's obviously I suppose one of the concerns might be if you use prokinetics to get that going and you've got an intestine that's healing. What's your thoughts on that?
Well, I wouldn't be jumping to that at that stage. To me, again, at this stage, it's all about the analgesics. And another analgesic we use quite commonly now, intra-op and then post-op, probably for that first 24, maybe even 48 hours, is lidocaine 2. So we often put them on lidocaine infusion. It's really good for visceral pain. It's helpful for those. And we'll talk to anaesthesia, and often they may come in with other analgesic techniques we'll use as well. But those are probably the 3 things: the opioids, paracetamol, lidocaine initially, and then we'll start to wean back off that. But if you can get those patients as comfortable as possible initially, then things get easier. And coming to that ileus issue, we do see ileus, and the worry with ileus, so that gut stasis issue is, well, what's the signs of ileus? That's a dog that's not feeling very comfortable because the guts aren't moving. They maybe get some nausea, some vomiting associated with that. So some abdominal pain. What does that look like? That looks like a dog that potentially is maybe getting a problem with a wound dehiscence.
I suppose, which is, I suppose we'll come on to that a little bit later, because that's all part of our monitoring, isn't it? But I suppose we do the analgesia, feeding. What about timing of feeding?
And again, this is all about the same thing. So it's trying to minimise the ileus issue. So, I'll be definitely thinking towards that. I'll be, in the past, people used to starve these dogs for 24, 48 hours or longer. Well, actually, our view is, look, if it wants to eat, even as soon as it's woken up, we'll give it a small amount. And something which is easy digestible, you know, some you know, sensitivity type sort of diet sort of stuff. We'll start on that. We'll offer it. They often don't eat it, you know, the first few hours overnight, or but by the next morning we'll be hoping starting to get some food in. I mean, it's important just from a general nutrition point of view, you know, because some of these dogs may have not eaten for a while. They may be in some degree of
enterocytes, might be a bit hungry.
Absolutely, and that's a key one actually. That we know that the enterocytes are fed from the gut. You know, so you got to feed them to do that. And I think the other key one is really, you know, if you think by not feeding, there's like no luminal fluid anymore, there's nothing in the gut anymore. Well, we just know that's not true. Actually, and also. We really want the guts to start moving again, you know. So feeding helps that. Yeah, absolutely. So thoughts towards not feeding. I mean, really, no. We try and feed them as soon as we can. Palatable, easy stuff to eat. You know. We'll also then start thinking about, again, this is sort of towards the ileus issue and some of the issues that can come with that, and trying to avoid this is, we may think about, you know, putting on some antiemetics. You know? Okay. Yeah. So. You know, more often something along those initially. Often they're a bit nauseous still. We'll watch that. We might put them on, you know, an antacid, so you know, omeprazole, something on those lines too. You know, and
then I suppose slightly. I mean, it's a big topic that we can't really cover in detail. If you've had you know, contamination, then obviously you're going to consider antibiotics.
Absolutely.
Any particular antibiotic, or?
Yeah, I mean, I'd probably continue on with. You know, if there's been significant contamination, or certainly if I'm worried about viability, I mean, absolutely, if there's an active infection like a septic peritonitis, which is again, that's a whole different topic.
That's a 5-hour podcast.
But you know, we'd probably have them on intravenous antibiotics at this stage. You know, because again, we may not be sure that they're actually, if you give it orally, that it will getting in there.
Because ileus,
vomiting maybe still a bit nauseous. So we'd probably go with intravenous antibiotics. Probably it's cefuroxime. You know, which would be the normal one we'd use, and we're using that probably every 8 hours, you know, around that sort of interval.
For how long would you? You know, I suppose for I suppose
well, it's a tough one. I mean, I think again, if there's a concern with viability, or there's been a contamination issue, so there's a real good rationale to give them. Then we'd go with those until they're eating, and then we'd probably follow on with probably you know, another second-gen cephalosporin, you know, and we'd continue that until the point where we think that actually we should be over that phase. And that's, again, we talked about this in the first one, the podcast, about the whole issue with healing. And so I'd probably be thinking I'm going to follow that to day 10, say. But then, but I'm not going to go for that for 3 weeks. I mean, there's no sense to that, you know. Now, on the other hand, it's a really interesting topic, because say if it's just being not a linear foreign body, just a standard foreign body, you know, simple one, it's come out really straightforward. You've done a little enterotomy, it's come out really easily, it's nice and clean.
Swab packing.
Exactly. I'll have no antibiotics during the surgery, but I won't follow on with them afterwards, because there's not a good rationale for that. You know, there's not an active infection. You're actually, we know these days, you just select for antibiotic resistance. Absolutely. So no benefit to that.
As you know, one of my pet topics, so big advocate of that.
Definitely. But I mean, I think the other challenge for these dogs actually then is, it's the post-op monitoring plan.
Absolutely, which actually is as important as the actual surgery. So,
well, maybe not as important.
Well,
but it is important.
All right, fair enough. So what we're gonna monitor and why?
Yeah, well, I think I mean, to me, it's actually, look, you look at the patient first. So look, you know, so we'll be watching, you know, heart rate, resp rate. We'll be looking at temperature, you know. So we'll be looking at those things, and we'll be doing that maybe depending on, again, the severity of the patient. But say there hasn't been a contamination, surgery's gone well, we're happy. We'll probably be looking at that every 6 to 8 hours. 6 to 8 hours. While it's in the hospital.
So how long do you hospitalise them for?
I see. Again, that's a real interesting one. I mean, because that actually depends on the patient, you know. So if that dog, you know, day or two out from surgery, it's comfy now, it's eating well, it's looking good. Well, what's the rationale to keep it? You know, because we talked about when the risk period for dehiscence is. And to me, I mean, this is interesting. When I realised when that risk period was, I thought about, well, where's most of my patients? Well, most of my patients are at home. Absolutely. So actually, there's a real important element there to educate owners, where I'll tell them, look, if you know a dog who's improving, eating now, looking comfy, if it goes off its food, if it starts to vomit, you know, if it starts to become really quite lethargic and dull, starts to develop some signs of pain, you need to get on the phone, you need to get the dog right back as soon as possible.
So so he's gone home, but he still could dehiss.
Oh, absolutely, yeah, because we talked about that risk period, particularly that 3 to 5 day phase when they can get a problem. So I'll tell owners that, you know, I'll tell them face to face. I'll write it down for them. You know, so it's all there so that they know what to look out for.
Okay, cool.
Because once you start to see some signs of that, you want to get it back in
quick.
You want it top of
and I suppose if you've got an owner who gives you that phone call day 4, for day 4,
say,
bit off colour all of a sudden,
looking
a bit hunched, come in and you think there's tummy pain there. So
I
suppose one of the immediate thoughts is dehiscence. So how do we?
Yeah, no, completely. I mean, again, so you're checking your parameters. You know, is it spiking the temperature now? It wasn't before. Systemically, you know, what's it looking like? You know, so it's just a general veterinary assessment that we're putting into play. I think then that's that question. You know, you're worried about the dehiscence. You're worried that there could be an issue there. So you're looking for the signs that could suggest that. And the key thing probably we're looking for is signs of abdominal fluid.
So that's going to be ultrasound.
Ideally. I mean, old techniques where people used to just do blind taps or, you know, lavage of the abdomen. I mean, we don't do that anymore.
And there's a bit of a challenge in that post-op period because everything's a bit brighter anyway.
No, sure.
And so you've got air in the abdomen if it's very...
well, you probably expect most of that to be gone by that stage,
I suppose if there's air in the abdomen at day 4...
There's a concern. But that's it, it's fluid actually. So you're looking for fluid. And again, you might expect a small pocket of fluid. And some of me feels, well, is it easily tappable or can you easily get a sample of that? If there's like a really small pocket you can see in between a couple of loops and you think, I'm not going to get into that, I'd watch that dog. I'd probably hospitalize it, re-ultrasound it again 6 or 8 hours time, see is it changing. You know, so you're watching to see what the dog's doing then. On the other hand, if there's a pocket that you can sample, you sample it and you look at it in-house and yes, you'd expect some inflammation, but if you're seeing lots of neutrophils, you're seeing those as degenerate neutrophils. If you see any bacteria, you should not see that at that stage. You know there's a problem, and that's a septic peritonitis. That's going to need action. And those are challenging patients. And they take a lot of input, and they're going to take significant sort of care, ICU care and supportive care to get them through what's now a major systemic problem for them. On the other hand, I think the interesting ones are when you look at them. You see a tiny amount of fluid, you don't see much, but you think, oh, hang on a second, what's going on? And this sort of brings you back to that ileus concern. And that's that key one, I think, for those first few days, has it got gut stasis? So maybe with ultrasound again, you might get a feel for the gut's moving. What's that like? And I mean, what do you do? Because you often deal with those guys, I mean, what do you put them onto?
Well, I mean, if you're happy, obviously consult with the surgeon.
Yes.
But I suppose from a prokinetic point of view, I'll typically try a metoclopramide infusion first. I mean, you'll read about ranitidine, but I mean, it's probably quite a weak prokinetic. It makes you feel like you're doing something, but metoclopramide's the one they use. I mean, erythromycin is quite a potent motility stimulant that stimulates motilin, so you're going to get some big waves. And I've never had a post-op ileus. I mean, that's not a drug I'd use in that situation. So for me, it tends to be a metoclopramide infusion. And I personally, I find, in my experience, when I'm using it as an infusion, it's a lot more effective than subcut injections. Typically these patients need fluids and electrolyte supplementation anyway, so it all just goes hand in hand.
And it probably actually comes back to the analgesia thing as well. Like some of these dogs are actually painful, and that's the reason it hasn't eaten, and that's why it hasn't sort of got things going. So it's actually good nursing care.
Absolutely.
Often required.
Cool. But hopefully we'll monitor these patients and they won't dehiss.
Sure.
And they'll make a successful recovery. And I mean, is there anything else you think we haven't covered?
No, I mean, I think the thing with the linear foreign body is they are more challenging. There's more to them. Systemically, sometimes they can be really quite sick. Particularly there's that risk of rupture already. So they come in with a septic peritonitis, which is just occurring or is well established. So they can take a lot of input. They can be really quite difficult cases. And they do have an increased mortality rate. Studies would suggest that. But on the other hand, if you get them early, you treat them with a lot of things we've talked about.
Move them, in that stepwise manner, starting off at the top where the anchor is.
Getting through that. I mean, and then particularly you know, keep on top of that analgesia, the nursing care,
Yeah.
the feeding, you know, all those key post-op things, and then that good monitoring afterwards. Well, you know, they should do well. And actually, again, there's some studies which show excellent, you know, survival, you know,
Cool.
rates, you know, 95% plus. So
Cool.
yeah.
Cool. Well, thank you, Ronan. We
good,
shall
man.
have more beer.
Yes.
Even though I'm behind you. Hope that was useful. We'll be doing more Davies Out of Hours podcasts over the coming weeks and months. Hope this one was useful. And if you have any suggestions for future topics, then please give us a shout.